Good morning, everyone. I'm Dr. S. Today, I'm privileged to present you Dr. Silvia Martins. Dr. Silvia Martins has an associate professor of epidemiology at Columbia University. She's the founding director of Substance Use Epidemiology Unit in the Department of Epidemiology, Columbia University, Mailman, and director of Columbia's Policy and Health Initiatives on opioids and other substances. Her current research focuses on consequences of medical and recreational marijuana laws in the U.S., recreational marijuana laws in Norway, prescription drug monitoring programs, the synergistic effects of opioid policies and marijuana policies on opioid-related crimes, and gambling and impulsive behaviors on minority adolescents in the U.S. I now present to you, Dr. Martins.
Thank you. Thank you so much. It's a pleasure to be here today as part of the conference. And today I'm going to talk about some work I've been doing with colleagues here at Columbia and also in Brazil in regards to COVID-19, mental health, and substance use, both in Brazil and in the USA. So just a brief overview of what I'm going to present for you today is I'll start like talking a little bit about Brazilian data on COVID-19 vaccination among vulnerable populations, so people that use drugs. Then I'll present some results from work done by some of my colleagues at UniFesp together with PHIOS on alcohol use patterns in Latin America during the COVID-19 pandemic with a specific focus on Brazil. Then work I did with one of my postdoctoral fellows and one of my doctoral students on alcohol sales during COVID-19 in the US. Then finally, some work I did together with colleagues in Brazil on I think one of the few samples focusing on people with mild COVID, that is like people that were outpatient COVID patients and mental health status in Brazil. And I talk a little bit about future directions on projects in these areas. So just starting like giving an overview, and you're probably familiar with this data. Like as of now, like from official reports, Brazil has had about like at least 22 million cases of COVID, and we believe this is underreporting because the country hasn't tested that much. Like we believe that number of cases might be even 10 times higher. And as of yesterday, there were almost 610,000 deaths due to COVID in the country.
Yeah. Sorry to interrupt, Dr. Martins. We cannot see your screen if you're sharing.
Oh, you're not?
No.
Let me just try it. Let me just try it again. Okay, let me just see what's happening here. Okay, let me end the slideshow. Can you see it now or not?
Not yet.
Not yet. Okay, let me try to share it again. Okay, let me just check. Let me just restart it. Okay, let me just start again. Okay, let me just share it again. Sorry about that. Yeah, file open. Okay.
Yes, we can see it now.
Okay, but you're now seeing also the Zoom, my personal Zoom. So let me just let me put it in slideshow format and let me know if you can see it now. Can you see it now?
Yes, it's all
perfect.
Okay. Thank you. Yeah. So okay. So I already talked about this overview. I already talked about the numbers in Brazil. So and this is data from 2020 in which like Brazilians were dying in staggering rates due to COVID in early 2021, very similar to the situation here in the US. And And as you probably know, Brazil has been known, like in the developing world, as a powerhouse for vaccination. And there were reports of Brazil has always been good, like in vaccinating the population. But in the beginning of the vaccination program, of the COVID vaccination program, everything was going wrong. Everything was going wrong. I'm happy to say that now things have changed. Like as of now, like at least 130 million people have already been vaccinated in Brazil, and that corresponds to almost 76% of the population has taken at least one dose of vaccine. 57% of the whole population is fully vaccinated, and they just started vaccinating adolescents about 2 months ago. And also, in addition to that, a few people that are eligible, particularly like healthcare workers and older adults, have already 5% of them have already taken their booster shots. Yeah. So vaccination is no longer a problem, and it is among the countries. It is among the countries with high rates of vaccination compared to most of the other countries. Yeah. However, like in the beginning in 2020, Brazil had a plan to vaccinate vulnerable population, including people that were in house, prisoners, descendants of enslaved Africans, and also people that use drugs. But it wasn't working in the beginning. It wasn't working well in the beginning. So this is just to show, like, this is one of the drug scenes in downtown São Paulo, where people that use crack cocaine aggregate. This is where, and the plan was like to vaccinate as early as possible people living in these conditions. So I and colleagues at Unifesp, doctors Vitor Tardelli and Thiago Fidalgo, called attention to the situation and why it was important to vaccinate people that use drugs that are in among socially vulnerable. And then the plan particularly in São Paulo and also in Rio was to do an outreach program for people that use drugs, like focusing on giving them like the Janssen vaccine. So teams there also offered snacks as an incentive to immunization, and there were a mobile unit delivering vaccines, trying to avoid conflicts with the local police. So this is just to show like the teams going there and vaccinating the population. And as of now, like after initial hurdles, they have been successful in vaccinating the vulnerable population of people that are using drugs, specifically in São Paulo city. So now switching gears, I'm going to talk about about alcohol use in COVID-19, and this is a study that was conducted by also some of my colleagues, some of my research collaborators at Unifesp, including Juliana Valente and Zila Sanchez, who was my former postdoc and has been a research collaborator for many years. So what they did together with PAHO is they did an anonymous online survey that was developed in 4 languages: English, Spanish, Portuguese, and French. They also included the Guyana, but I think they only collected data on very few people in Guyana. They collected data early in the pandemic between the end of May and the end of June. And they included 33 countries in Latin America and interviewed people that were 18 years of age and older. They covered topics such as demographic, COVID-19 related questions. They also assessed alcohol consumption in 2019, alcohol consumption during the COVID-19 pandemic, and also they attempted to assess like mental health impacts in the last 14 days. So this graph just showed like the number of respondents by country, and it was a convenient sample. So you see that Brazil is really overrepresented compared to most of the other countries, even compared like to large countries such as Argentina. Yeah. And most of the respondents were females, more than 65%. It was evenly distributed among like younger adults up to age 49, with less respondents ages 50 and older. About 41% of those interviewed self-identified as white. 4% self-identified as Black, and 1.5% self-identified as Indigenous. And what I think is interesting about 50 to 53% of the population self-identified as mixed race or unsure. So these graphs just show like the prevalence of drinking by sex in 2019 and in 2020 by different subregions in Latin America. And interestingly, what we see is that in most cases there was a decrease in the prevalence of drinking across all regions of Latin America. But then they went a step further and they wanted to look at heavy episodic drinking by age. So that means like people that are engaging in binge drinking, or people that are drinking more in each episode. And they looked at these changes from 2019 to 2020, and the pattern was also overall mixed. So there were decreases in drinking patterns in some situations, as shown in the top part of the graph, but and it varies by age group. But also we see a subproportion of the population, depending on age groups, in which we see increases in drinking, which could be related to stress due to pandemic. But interestingly, for at least like for the younger age groups, like about a quarter of the population reported there were no change like in heavy drinking in their drinking patterns during early during the pandemic. So it's kind of a blurred picture. Parallel to this work that was being done by my colleagues, like I and colleagues here at Columbia, we wanted to look at patterns of alcohol sales during the pandemic here in the United States, because there were anecdotal reports that people were consuming more alcohol, specifically early in 2020. So why did we do this? Why did we do this work? So it is known that alcohol and other substance use can increase during periods of high stress and social isolation. And at that point in time, the evidence on alcohol use during the pandemic was contradictory. There were like some early reports showing increases in alcohol use in Europe and also here in the US. But as shown like in the PHIOS report, there were some early studies showing that different than what was being seen like in the US and Europe, there were patterns of decrease in alcohol use in some Latin American countries and also in Australia. And also we thought it would be interesting to try to differentiate between like alcohol use like in restaurants and bars that were closed early in the pandemic and household consumption. So at that time, what we did is we decided to look at retail store sales data as a proxy for household consumption of alcohol and check if there was any increase in these sales during the COVID-19 pandemic. So what did we do? We used at that time like data from the monthly retail trade survey, which is a representative sample of retail sales in the US. Our outcome was retail alcohol sales that we defined that as a proxy for at-home alcohol consumption. And we looked at patterns of alcohol sales from early in 1992 until September 2020, divided in quarters. So we did like descriptive analysis and then followed by multivariable Poisson regression with cubic splines. So this is just like, I know this is an overwhelming graph showing like changes in annual monthly sales across time ever since the early 90s. But I'd like you to look at the bottom of the graph. This is a heat map at the bottom of the heat map, and where you see like a huge increase from March 2020, a huge increase in sales from March 2020 onwards. And this is showing like the differences in monthly beer, wine, and liquor sales across time. So, and this graph like just translates what we had in the heat map to more digestible graph. Sorry, I think at least for me, I'm showing I'm showing on top of the graph, on top of the graph. So the blue line represents like the beer, wine, and liquor sales, and as a proxy for at-home consumption, and the yellow line represents like the food services and drinking places that were closed early in the pandemic as a proxy for drinking place sales data. And we see like a sharp increase like in beer, wine, and liquor sales from March 2020 until September 2020. So let me just moved, sorry, now I moved myself, so I cannot move the slide. Where do I, let me just minimize here. Okay. So we saw, so in our analysis of alcohol sales data, we saw a significant increase in retail alcohol sales during the pandemic in the US. And at the same time, we saw that food and drinking places alcohol sales decreased during the same time period. And we were calling like for future work to explore alcohol use among people at the highest risk for COVID-19 infection and among people that were affected by social distancing measures that were in place last year. So now moving like to the research that we did together with colleagues at several institutions in São Paulo, looking at depressive anxiety and post-traumatic stress symptoms among patients with mild COVID-19 in Brazil. So as you also probably heard, like during the conference, there was last year, like there was uncertainty around like whether a need to quarantine and having a COVID-19 diagnosis could potentially impact people's mental health. It is already well established that people who survive different types of critical illness can develop later on like depression, anxiety, PTSD. There is also a clinical relationship between COVID and potentially developing depressive and anxiety symptoms post-infection. At that point in time, it was still debatable, and we thought there was a need for studies assessing psychiatric symptoms post-infection. So we aim to investigate the association between having COVID-19 symptoms and post-infection depressive and anxiety and post-traumatic symptoms. We also did similar work with substance use that I'm not showing today due to sake of time, but we also have a published paper looking at relationship between COVID-19 and different types of uses of substances. So our study design, like we were lucky to have research collaborators in a city that is part of São Paulo city metropolitan area. So we conducted a prospective cohort study in São Caetano do Sul, which is in São Paulo city's metropolitan region. And we were lucky to have access to data from all patients 18 and older who tested positive for COVID and had a mild case. And we defined them as mild cases as people that didn't need hospitalization, that only needed to be followed up, in an outpatient way. So they didn't have like complications. They didn't go to the hospital. They didn't go to the hospital. They didn't need to go to CTIs, and they weren't at risk for death. So what we did is we followed up the patients up to 14 days from their initial questionnaire. All of them answered the GAD-7 to assess anxiety symptoms. All of them answered the PHQ-9 to assess depressive symptoms, and all of them answered the PCLC to assess post-traumatic stress disorder. So in this study, we interviewed 895 participants. Most of them, 60% were female, 51% were married, and 60% of them had up to high school education. In this prospective sample, 20% of them acknowledged that they already had a lifetime psychiatric diagnosis, mainly depression and anxiety, prior to the pandemic. All patients related like being of 4.2 COVID-19 related symptoms. The most common symptoms were loss of smell, coughing, headache, and fatigue. And then when we looked at post-infection depression, anxiety, and PTSD, we saw that about a quarter of the sample reported depressive symptoms, a little less than a quarter anxiety symptoms, and 17% reported PTSD symptoms and these were all symptoms that happened after they were infected, and that happened after they were infected. Yeah. So we aim to look at whether total number of COVID symptoms were associated with outcomes of either depressive symptoms, anxiety, or PTSD, or PTSD. And what we saw is that having more COVID symptoms was associated with reporting depressive symptoms, anxiety symptoms, and also PTSD symptoms. And we did like several different models and adjusted for having a prior diagnosis of psychiatric disorders, and also adjusting for whether they were under psychiatric treatment or not. And also other social demographic confounders. So at least in this sample, we saw that exposure to more COVID-19 symptoms and having more COVID-19 symptoms that may be associated with future depressive, anxiety, and PTSD symptoms. And it is also possible, like during that, the social context of the disease was contributing towards increased psychiatric symptoms in this particular sample. And then we called like for early mental health intervention among people with mild COVID. And this is a unique sample because it is a sample of people with mild COVID, and our colleagues in Brazil are planning to continue following up this particular sample, like to look at a myriad of other outcomes. Yeah. So just to talk a little bit about future work in the area related to COVID. So in my US based research, we have a NIDA supplement to look at COVID-19 and opioid related harm outcomes, including opioid overdoses in chronic pain patients with using New York State Medicaid data, but we're still early in the analysis, and I'm not allowed like to show the results today. We're also doing work looking at social safety net, particularly unemployment insurance on opioid related harm outcomes and psychological distress post-COVID using US data. Also recently submitted a project to do machine learning of big data on COVID-19 mitigations and economic policies and substance use data to NIH that I hope might be funded soon. And also waiting to hear, like, so we put together a few months ago, well, actually many months ago, like a transnational team with US, Brazilian, and French investigators to do work on COVID-19 substance use and mental health data. And we're waiting to hear on whether we're gonna be funded. And this would be like an extension of this work like done in São Caetano do Sul, but also with similar samples both in the US and in France. But we're waiting to hear whether or not it will be funded. So I'd like to acknowledge all my colleagues involved, like in these different projects, including like research assistant, doctoral students, postdocs, and master students. Also, all my colleagues at Unifesp that were involved, like in the PHIOS study, or in the study calling like for vaccination for vulnerable populations, people that use drugs, and also everybody that collected the data for the project on mild COVID patients at the University of São Caetano do Sul, because without them on the data collection team, we wouldn't be able to have access to the data. And also, besides like all the research colleagues, I'd like to acknowledge like all the mild COVID patients in Brazil for giving their time for us to assess like their COVID symptomatology and also psychiatric symptomatology. So thank you, and I'm open to questions. Yeah.
Hi, Sylvia, it's Larkin, and I appreciate this so much, and it's been amazing what you've been able to accomplish in the midst of a pandemic, actually, with people in Sao Paulo, and because I know that wasn't easy. But you know, I have like I have an interest in asking about the because we gathered a lot of data from college students during the pandemic, and you know, we did agoraphobia, we did PTSD, we did trauma, and a lot of those things aren't quite clinically, like, I mean, agoraphobia in a pandemic, I mean, symptoms are you don't want to be in large crowds. Okay.
Yes.
You know,
Mm-hmm.
so I've always been somewhat hesitant to declare it like, okay, it's PTSD, it's agoraphobia. It's just, it's symptoms of what they're going through in a pandemic. But one thing that actually, there was one chart you had up. I mean, I'm really interested in knowing more about the market sales of alcohol. Because that, I mean, we always thought that was an American thing, that alcohol sales went up, but to see it in different locations is, or different countries is
So,
interesting.
yeah, no, so just to clarify, the market sales was US data. That's research done in the US. We could potentially try to get similar data from other countries. Yeah,
I think
from
that would
other,
be interesting because different countries had different lockdowns.
Yes, yeah. And even like if we were to talk about lockdowns in Brazil, it's just like the US, like lockdowns varied by area of the country, by state, and by city. There was great variability, in the level of lockdown. And so that is,
but I just haven't seen a paper out there that says, how did alcohol sales differ by country?
Yes, I can probably discuss with my former postdoc if we would have bandwidth to do that and to gather the data. Like, as you know, like it is sometimes it is way easier to gather this data in the US than in some other countries. But I agree with you.
We can get a master's student. That's a great thesis project for them.
Oh yes, for sure. Maybe I can convince some of my current master students, but all like at least like all my current master students like all want to work like on the area of opioids and US data.
No, but I would like to see a paper about, or a news article about how alcohol sales differed by country.
Yes. No, I absolutely agree with you. And one thing that I didn't show today, like I had more data to show, but I thought like that it would be overwhelming. Like in the same sample in Brazil with mild COVID patients, we assessed changes in substance use, and we assessed like alcohol, benzos, which is something that the prevalence is higher in Brazil than in other countries. Benzos, cannabis, and we didn't see a really clear pattern. That's also one of the reasons why I didn't present it today. Like, we didn't see a really clear pattern. We saw some changes. We saw some changes in use. We saw some increases in use that we believe might be like people trying to self-medicate these new like anxiety, depressive, and PTSD-like symptoms that might fade away now that the situation has changed. But we didn't really see a clear pattern. But of course, like in this specific cohort, which might be different like than the general population. Yeah.
Yeah, and the reason I bring that up is because I think not only in the US, but maybe more globally in different countries, economic health disparities
Mhm.
is that, or the the differential between a high and a low middle class
Mhm.
is that it really, we know in the US that the COVID-19 has impacted um, lower SES uh, groups. And so uh, yeah, I
Eh,
just
I
saw
yeah,
even in our college data or
mhm.
even by age differential, I mean, young people don't have a lot of money to spend on alcohol, especially in a pandemic. And so somebody's buying the alcohol.
Yes, yes, yeah,
And
yeah. So
so I think it has to be, if people who are buying the alcohol, it should correlate. At least we could do an ecological study
yes,
that it should correlate with those who have more, who in the proportion of the population has more money,
it could potentially, but then again, like in some countries, depending on the type of alcohol can be really cheap. Yeah,
Yeah,
alcohol can be
yeah,
really cheap. And talking about COVID, like I would say, like the similar to the US, like in Brazil, like there are reports like of people that health economists and social epidemiologists, they have already shown that the population that is most affected by COVID is the low SES, is a low SES population. That's where like there were more cases, that's where there were more deaths. There were more deaths, like particularly like before
yeah,
vaccination
yeah,
was widespread. Like the difference, I would say one of the big differences between, like, for example, Brazil and the US is that despite the early spread of misinformation and vaccination mistrust, for whatever reason, like the Brazilian population is really almost 99% of the population wants to be vaccinated. So that's why like the vaccination rates are becoming higher and are becoming higher and higher as vaccines become available. Like people really want to be vaccinated. Like they might support like people that spread misinformation, but they still go and get vaccinated. And so
yeah. Well,
it's a cultural issue different than here. Yeah. Mhm.
that's a whole other study about what's the different public health messaging, because um between Brazil and US, or maybe it's the acceptance of, I mean, I'm really interested in vaccine hesitancy.
Mhm.
And it's from what you just described, it's very kind of different. I mean, we
Yes.
have a 30% holdout here
Mhm. Mhm.
by pretty much by profession, economic class,
Mhm.
and or
There.
even demography too. But yeah, I think this is so, there are many ways to look at the data, but I applaud you. I mean, y'all have done tremendous work through this
Yeah,
pandemic.
thank you. We tried to get funding to do like to compare data across countries, and we submitted a rapid R21 to NIDA, but just the caveat was that for rapid R21s you cannot ask to analyze, you cannot ask to collect data outside of the US, and they only told us after it had been reviewed. Yeah, so
Oh,
yeah, we
oh, well,
missed
you know
that.
what?
Yeah. Mhm,
We
mhm.
should talk, because we have collaborators in South Korea and I think in Taiwan, that we should figure out how to create a compendium, and it
Mhm.
might not be funded by NIDA, but we could have someone figure out how to harmonize the data. And um I think that would be novel.
Yeah, I didn't put in the last slide, but I together like with one of my former postdocs who's now faculty at Penn, like we just a month ago we just submitted an R21 to look at vaccine hesitancies among people that use drugs, but it's only US, it's mainly US focused. Yeah, it's mainly that yeah, it's mainly US focused. Yeah. But I was kind of disencouraged, like when, so I and Jeremy Kane had submitted last
Oh,
year a grant,
okay.
in which we had like international sites, including Brazil and other sites. But then they just told us no, rapid R2. We probably
Yeah.
didn't read the RFA correctly also, but we don't fund research. We don't fund research with for this specific mechanism, like with international data. So it was a bummer. And then like we were both, I and him and our collaborators were busy with other things. So we just
Well,
forgot about it.
we
Yeah.
should talk about that because we had vaccine hesitancy data on the national college COVID study that we did that is, it was interesting because it was before Delta
Mhm.
and variant and before colleges mandated that students be vaccinated
Oh yes. Mhm.
come back. And so yeah, no, you and me and Jeremy should
Yeah, we
collaborate.
should talk. Yeah, of course. Is there anybody else that has questions? Yeah. Or,
Thank you, Dr. Martin. This is Ellen G. Denton. I am here in Guyana, greetings from Guyana, and Larkin, greetings. I agree with Larkin. I was amazed at how productive you were this past year. Thank you for sharing.
Ellen
your
G,
data.
you need to speak up into the mic because it's a little hard.
Is this better?
yes.
Okay.
Mhm.
So I wanted to say thank you for that presentation. And we were amazed, we were sitting here in Guyana, amazed, agree with you totally, Larkin, that you were so productive during the pandemic. And the data was just so interesting, it really told the story. Thank you.
Mhm. Thank
I
you.
have a basic question, and then I have a question of how it applies here to Guyana. So my basic question was, you showed a bar chart with 4 different groups. I think, can you just give us the distinctions between those 4 different people groups here in South America? That's the basic question. It was the prevalence of drinking, and it summarized that drinking had increased by among men and women and the total population during COVID-19 in South America.
Is this one?
We're not seeing.
Oh, you're not seeing, let me just go back. Oh, I think it's this one. Yeah, okay. Let me just share my screen again. Let me just end it here. Yeah, sorry. Share screen. Yeah. Okay. Okay, let me just share. Is it this one?
Yes.
Yeah, so just to clarify, this is not my work. This is work like with my colleagues at Unifesp, and together with PAHO, Maristela Monteiro at PAHO. Yes, yeah. So I just thought it would, like, because of the audience, that it would be interesting to add this as part of the presentation. Yeah. So
it is because here in Guyana, there's such heterogeneity in the people groups. And so if you can, do you know the distinction between the groups or how one would identify and classify?
the distinction, I'm sorry, it's hard to hear you. The distinction between what? Between the groups?
Classifications of these 4 different groups.
Also the further stratification between these groups? No, I don't know in detail, but they have a report. So it's in here. The report is here. It was published in the Revista Panamericana de Salud Pública, and they also have a report, a PDF report at PAHO. Yeah, and if you see, and just like, let me go back to slide 18. If you see here, like, you can see that this was a convenience sample. So you can see that Brazilians are overrepresented in this report. Yeah. So they interviewed. So for example, just like, it would be wrong of me, like, if I were like to just report, for example, just data on Guyana, because only 30 people in Guyana answered this survey. Yeah. So I think like some of the results need to be taken with a grain of salt, but I don't know those details, but I would recommend like going to, I know it is available in the internet, the PDF is available, and also the original paper. Yeah. Uh,
Thank you.
Yeah.
And my follow-up question was, yesterday, here in Guyana, they reported on substance use also increasing. And one of the explanations by grassroots leaders who are working to intervene in substance use here in Guyana was that alcohol use increased in the home, and thus youth are more exposed to alcohol because the home was well stocked with alcohol, and parents were introducing alcohol to kids probably as young as 9 or 10 years old here in
oh
Guyana.
my. Mhm.
And so, and certainly this occurred during the pandemic. What do you, I know your data focused on adults. However, do you have any thoughts about increased exposure to alcohol use as a result of pandemic social isolation and just the increase of prevalence use in the home, and any implications for the entire family there?
Yeah, I think for sure you've been more exposed, more exposed to alcohol at home, and that could have implications for the future, but it also is tricky, like depending to what type of exposure they had and for what duration. So my suggestion in these situations would be like check what can be done, like now that like schools are fully open, what can be done in terms of prevention programs, to prevent like alcohol initiation and escalation like to binge drinking and heavy drinking. Yeah, and the heavy drinking. So particularly particularly if you're saying like that they were offering drinks like to 9 and 10 years old, so to 9 and 10 years old. So I would suggest trying to see what can be done in terms of prevention at schools and with parents. Yeah, so that people are aware of the harms of starting drinking at such an early age. Yeah.
Thank you. That was exactly I think the sentiment here yesterday as they were presenting on alcohol use as well in Guyana. They were trying to implement before getting to suicide prevention, they were trying to implement alcohol prevention to kids, but the difficulty here was the twofold. One, law enforcement was involved, and they identified that youth are less likely to tell where they're getting alcohol from, how they're getting it. I think Larkin spoke a little bit about this among school-age university students who, during the pandemic, how being able to afford alcohol is difficult. So that was one, and there was much experimentation here in Guyana for young adults and young people, and they were getting alcohol and just experimenting. And then two, not being able to hear the truth about where they get it from as they're protecting their peers. So one place that they did identify they were getting it from were their parents' cabinets. And because the prevalence of alcohol use increased during the pandemic, there was more available in their parents' cabinets.
So that again means there needs to be like prevention work with the parents. So it's similar, for example, to a situation pre-pandemic here in the US, like with the opioid crisis, with the opioid crisis that has been ongoing for many years. And we know that, for example, sometimes the first exposure of adolescents adolescents like to an opioid and using it non-medically is from their family's medicine cabinet. Like, so the parents or the grandparents have leftover medication from either a surgery or like a dental procedure, and the kids hear at school or from friends that it will give like a nice high, and that's where they get it. So I think it has to be like a multi-pronged prevention approach, where you have to involve like not just the schools and the teachers, but also the parents. So one of my colleagues, like from the PAHO project that I presented, so Zila Sanchez in Brazil at Unifesp, she leads like several alcohol and drug use prevention programs in Brazil, and they have, as of now, like I think they are doing some work in which they work directly with the parents, and they have like focus groups with the parents. I know the name in Portuguese. I don't know. I think it's based upon a European prevention program that they adapted to Brazil. And it seems to be working well. So it's a series. So the same way where you do like prevention programs in schools, where you have a series like of prevention programs like for well-being, preventing drug use, preventing bullying, preventing suicide, you can also do in parallel a prevention program with parents. And they did it, I think during the pandemic, they did it virtually and also in person, and also in person, focusing like on different communities and focusing like on vulnerable populations. I know it's an ongoing, and I know it's ongoing. I don't know what yet like the results, but there are several prevention programs where you can involve the parents, and I think it is most importantly like to give people the information. Give people the information about the harms that can happen, like if you start using some of these substances early.
Yeah. Thank you so much for that. I think that will be a really relevant primary target, and I will pass that information along to the substance use presenters down here in Guyana, because the miseducation for parents and just targeting parents, if there's a prevention program already designed for parents.
Yes, there is.
That can be adapted. I think that will probably be the most lucrative target to begin with. They have certain things in the schools here, but as you said, the parents are the ones who might not be understanding how to use alcohol, and they might not be intentionally introducing it to their kids, knowing that their kids are probably going to develop a dependence eventually, possibly. And so educating them and helping them to manage the alcohol that is in the home would be a primary target point.
Yes, for sure. And if you like, or the other substance use researchers in the country, like get in touch with me, like I can put you in touch like with the people that are leading these efforts, like not only in Brazil, but in other places, but in other places. Yeah.
Thank you.
No problem.
Thank you so much, Dr. Martins. It was a wonderful presentation and a very engaging conversation between Dr. Martins, Dr. McReynolds, and Dr. Denton. Thank you so much, Dr. Denton. Thank you so much, Dr. McReynolds. It was wonderful having you all in here.
Thank you. Have a nice rest of the conference.
Thank you.
Thank you. Bye-bye.